Hi, everyone. Welcome to our monthly webinar on trending beyond COVID-19. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare and the moderator for today's session. Happy New Year to you all. Welcome back if you've been joining us for the last couple of years. Now we are starting with COVID 3.0, so there's been lots going on, as you all know. And if this is the first time you're joining us, we welcome you. This session is being recorded, and during the webinar, you will be on mute. Please submit your questions using the Q&A function in Zoom. We'll have plenty of time for questions at the conclusion of Dr. Harris's remarks. The webinar recording will be posted on our YouTube channel, and a transcript of the Q&A segment will be posted on our website within the next couple of days. We share those links during the webinar so you can easily find those resources. We have a full hour scheduled. We expect a lot of questions today. So much has been happening. And those questions that we can't get to, we will answer in writing and post them along with the other questions on the website when we get the questions all completed. Now I'd like to introduce you to our speaker, Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and an Associate Medical Director. He's been our lead clinician for WorkCare's COVID response since the pandemic started. And now I'll turn it over to Dr. Harris. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks to everyone for joining us again. Obviously, there's a lot that has happened since we've last convened. First and foremost, Happy New Year. I'm glad we all made it to this point. And we know that there's a lot for us to do in the EHS community of professionals to help protect our workers in these unprecedented times. And that's what we're going to be talking about today. Compliance but compliance and worker protection. What should we be doing to fully understand how best to protect our workforce? And is being compliant merely enough to help with the protection of the ongoing concerns of the organization? So we'll dig into some of the details of that, best practices that we've seen amongst the employers that we serve nationwide and internationally. And we want to hear back from you all during this session. So we'll be doing a survey like we did back in November to get and hear from you to understand where you are in your process of being compliant and doing perhaps more to protect the workforce. So with that being said, let's jump into it here. You know the format. If you're joining us again, if you are new to us, we go through a business case that we begin with from a clinical perspective, followed by some causal examinations of what's driving the trend in the marketplace that we're seeing and in the clinical realm as well. And then we offer some thought leadership around how best to deal with these oncoming trends around COVID-19, followed by looking at some of the particulars and doing a deeper dive into the pandemic, underlying causes as it stands today. We talk about the fix, right? And getting into the details of what best practice may look like, followed by finally the messaging to our employees so that we're well-rounded with regard to our approach to protecting the workforce. So as we dive into today's session, we'll begin with where we were a month ago, right? So back in December, this is what we said on the webinar. Reversal of COVID policies will likely be necessary now, exclamation point. This was pre-Omicron surge, right? And so I'd like to say we did not misguide you in that, right? That corporate mandates of mask wearing, social distancing, and hygiene would all be reality again, and getting a head start on that before Omicron hit would be prudent to your organization. Now, I hope that everyone on this call adhered to that warning and put in place those protection mechanisms. So today, we want to talk about nothing different in that regard. Doing more than required is best it may be the best path forward for us. And so it's not a question of these mask mandates, mask wearing, social distancing being or may be in our reality. It is our reality. And we need to get ahead and stay ahead of Omicron, but we got to get ahead of new variants like the one that just arose in southern France, IMU. We'll talk briefly about that during this webinar today. So it continues that we want to focus in on primary prevention, right? We have talked about all three levels of prevention when it comes to COVID risk management during these webinars. But first and foremost, particularly during these unprecedented times, we want to focus our attention and our efforts to what can we do to protect the workforce from, one, getting sick, obviously, first and foremost, and two, how do we keep the numbers amongst the workforce at work? That is by far and away the largest concern amongst employers, is a consistent struggle, even amongst particularly healthcare providers like WorkCare ourselves, to keep warm bodies in the workplace productive versus at home quarantining and isolating, right? And so we'll talk about balancing those resources. Now, one of the best ways to do it, obviously, is engineering out the hazard. And we have just this week, Congress doing the same. The lead physician at Congress suggesting that all the Congress workers, the staff, as well as the Congress members, to work remotely, right? And so we know that during this surge of Omicron, that this tactic will likely play out again amongst all workforces, and we'll see how that augments our reality of workplace transmission. We know that's not sustainable, so we have to talk about strategies to protect the workforce at work, not just remotely. And as we talk about these strategies, I want to bring this back to the forefront of your consideration. What is the strategy for investment of resources regarding compliance versus worker protection? And so we showed you this graphic before. We want to reiterate this now so that we're all, again, in the same frame of mindset around what our approach should be. So compliance, in terms of our investment, is a straight line in regards to making sure we're doing the steps in place to for, in particular, the ETS, right, the emergency standard from OSHA, to hopefully not be subject to any fines. And we'll talk about those dates that we need to consider if you're not aware of them soon. But when we consider the cost of compliance, we know there are additional costs if we're going to go above compliance, and look at how those costs will provide return on investment for keeping our workforce productive, right? And we describe this as the additional protection zone, so to speak. And that's looking at the overall enterprise risk in an environment in which we had low incidence of local community. Unfortunately, right, as we all are familiar, today, as of today, no one virtually is in a low incidence community setting, right? And so our picture looks more like this, where the enterprise risk spread is broader, right? And we have high incidence of local community spread. And we know that adding additional resources to our protection may engender better return on investment for our enterprise. And we're seeing this again, hands down, that companies are engaged in the testing from a surveillance standpoint before the ETS has even been finally decided, right? And I think that trend is going to continue to grow because the workforce strains of keeping the workers productive in place has become untenable from a revenue standpoint or from a productivity standpoint. So with this frame in mind, right, we know that we have to consider what are those steps we need to be taking to be prudent in our protection versus compliance. So Omicron effect, let's talk about that, as we know that clearly is the cause of why we are where we are today, not just in the US, but abroad, right? But one thing we have to focus in on is the global population that is still susceptible continues to be profound, right? And that is the breeding ground for additional variants to continually emerge, and some say even more rapidly because of these particular pockets. And we know that in regards to how CDC is thinking about this, how our government and legislator is likely thinking about this, is the long haul, right? So so we know the dates that we need to be concerned about from an ETS standpoint is pretty clear. Looking to the ETS in regards to fines that will be levied won't happen before January 10th, right? January 10th being around the corner, and February 9th. And so those two dates, hold in your mind if you haven't already. I'm sure most of you, if not all of you, have. But those are the dates we need to have things in place for tracking first who's vaccinated, and having mask mandates in place secondarily, testing availability for those unvaccinated. And again, when we're talking about compliance, that is the concern regarding these dates. If we're talking about protection of the workforce, certainly these dates aren't as to be emphasized because we're seeing and experiencing impact now from Omicron, right? So again, January 10th and February 9th for what is to come. And we'll talk about what the Supreme Court will do and when here shortly. But this is where we were, again, a month ago, telling you before we encountered the surge of Omicron that the winter months would likely be worse than what we experienced previously, because we entered the winter months at a higher rate year over year, right, of cases. And so with that being said, right, we knew we were in for a ride, and we have experienced that surge at this point in time. And if we look at how poorly we're performing in reference to other nations, right, we're not at the top, but we are still high third in terms of the nations that we've been looking at and tracking since the beginning of this pandemic. So the United Kingdom, by far and away, hardest hit with cases per million, over 2,500, right? We're down at around 1,700 cases per million here in the US, Italy tracking there, as well as Israel. And we want to focus and take a time out to look at Israel. We know Israel has led the way in regards to boosters in their general population, right? Booster meaning the third dose of the mRNA vaccine. Israel led with Pfizer in particular, and they still experienced an Omicron surge, okay? And so that's important to play out. Again, future potential variants impact even in a fully vaccinated and boosted by far and away population, right? And this is why we're saying that COVID is going to be around for quite some time, and we'll reiterate that here later in the webinar. So we have to look at this data and understand that what we're experiencing is not particularly unique to our circumstance. Now, we're impacted by our circumstance in terms of those individuals who are unvaccinated in the US, but again, even in a 80% vaccinated population, right? UK is up there, Canada's up there, Israel's up there. We've reported on those numbers even just last month during our webinar of their performance of fully vaccinated being greater than the US, and they're still experiencing this spike. And we predicted that because of the mutations in the Omicron variant, it would escape our immunity and cause these infections to happen, okay? Now we want to look at not just cases, but look at why are we paying attention to this, right? Some are saying, hey, look, this Omicron, it's not that big of a deal. It's a common cold, the sniffles, and we want to put that to question, right? We want to look at the data in regards to, is Omicron causing a higher rate of death, a similar rate of death, or a lower rate of death compared to previous variants that we've seen? Right. And so if we look back at the different waves that have come, not just here in the US, but globally, we can see in the chart above the cases per million, right? New cases per million, and the waves associated with each of those emergence of alpha, delta, et cetera, right? And now looking down below that, we can see deaths per million, and we'll come back to this chart later. And we can see how, even though it's about a 3 to 4 week trailing indicator, that the number of deaths increased with previous waves. We don't see yet so far that dramatic increase in deaths if we fast forward to where we are now with January 4th data, up to January 4th data for the deaths that have happened due to Omicron. All right. So obviously that is promising news in regards to where we end up from a mortality rate of Omicron impact, but it's still not the end of it. We know we'll still see from the spike that just happened in the last 14 days, continue to drive up deaths potentially. We'll see to what extent. As we reported earlier, though, there is virtually no county in the US that does not have high sustained community transmission, right? And this is CDC data that we're reporting here. And we know that then that obviously is going to impact our strategy from a protecting the worker standpoint and keeping operations moving forward. If we look at data in regards to additional CDC data, in regards to chronic conditions, I'm pointing this out so that we can undergird why we're still, and this is kind of the focus of our next couple of minutes here, why are we still concerned about Omicron and COVID, and we're calling to question, right, whether it poses an increased risk of illness to our workforce and to the general population, right? Because we want to dispel any misnomers that Omicron is not that big of a deal or COVID is starting to become less of a big issue for us here in the US and abroad, right? And so this is a picture of data of chronic illness, 2018 data from CDC, looking at individuals that have answered yes to any of the following. Have you been diagnosed or told by a doctor any of the following health professionals of COPD, history of COPD, which is chronic obstructive pulmonary disease, emphysema, chronic bronchitis, heart disease, angina or coronary heart disease, heart attack or myocardial infarction, diabetes, right? What we know and what we've reported since day one of the pandemic is that each of these conditions increase your risk for a poor outcome from COVID, right? COVID-19 infection. And this is the potential impact from poor outcome nationwide, right? So 47.6% is the estimated number of individuals, right? Percent of individuals in the US 18 years or older that have a pre-existing condition. Right. If this number was 5%, perhaps we would not be as alarmed about COVID in the US, perhaps as we are today. But this is a substantial number of the population that may have poor outcomes if they become infected with COVID-19. Right. And so we want to continue to spread this message so that people understand death is happening. I personally, on a personal level, just last week, 3 friends lost immediate family members from COVID-19. One of them being only 2 years older than me, 43 years of age, no substantial pre-existing conditions. So we know that more and more people are experiencing loss of loved ones as a result of COVID-19 that could otherwise be preventable in terms of transmission. All right. So let's focus in on some thought leadership around Omicron in particular, and this notion that Omicron may lead to this massive global natural immunity and spell the end of this pandemic. You may have heard this suggested, I'm sure, and we want to look at this macro picture in regards to Omicron, not just in the US and abroad, and what that impact may be, all right? So if we look at where we were last year from WHO, they issued a scientific brief, and they were trying to get to the root of natural immunity and the characterizing the natural immunity that was imparted from a COVID-19 infection. This was May of 2021. And at the conclusion of this scientific brief, it was clear that suggested then that individuals who were infected by COVID-19 developed a strong protective immunity against COVID-2 infections in the future, right? What was unclear was still what was the duration of that immunity and how effective it would be from reinfection, all right? And so as we know today, that waning immunity from a previous infection still sticks to what we learned shortly after this scientific brief, which was about 90 days to 6 months tops would be the duration for increased protection against subsequent and reinfection, right? And we're seeing that obviously decreased even a little bit more with regard to Omicron's increased risk of infectiousness amongst those who have previously had a COVID-19 infection, right? And again, that only stands to increase the number of people in the workforce that are susceptible to being infected now and out sitting at home for quarantine or for isolation. And I know you're asking, well, hey, Doc, are you going to talk about the latest updates on COVID recommendations from CDC and quarantine and isolation? We can get to that at the end of the presentation because I know you're going to have questions about it. But I want to focus in on the underlying understanding of where we're moving as a trend in the future with regard to Omicron's effect on natural immunity amongst population and how likely it is that we're going to experience some silver lining, quote unquote, to this rampant infection nationwide and globally. And so it comes down back to this, right? Here's a picture of Omicron. We talked about how it has more mutations than we've seen previously in the spike protein region, which is how it binds to our antibodies, right? Over 30 mutations in that region, which imparts its ability to escape our natural immunity, right? And so as we examine these mutations, we know that our antibodies, once we're infected with Omicron, will form kind of a lock and key against configuration, if you would, against the virus itself, this version of the virus itself, right? And so the question is, will that lock and key that's established with this highly mutated variant of Omicron still be effective? Will that antibody still be effective against other mutated variants that emerge, right? And so we will start to understand that question pretty soon here in that we do have the emergence of a new variant out of southern France, all right? The understanding in this publication is that it may be probably of Cameroonian origin, right? And we're already seeing in this particular variant, a number of mutations, 46 to be particular, and those mutations again, affecting the spike protein and causing this variant to have perhaps a different effect on our immune system in regards to escaping the immune system, or obviously way too early to understand the effect from a severity standpoint on the population there, and understanding whether or not our vaccines will be effective against it, right? So again, the picture that we've experienced, not just with Delta, but now with Omicron, is going to continue for at least, most say, another 2-3 years, right? And that is why we're talking about now, how much should we be doing to not just be compliant with what's to come with ETS, but also continue to protect the workforce so that our organizations can continue to function and hopefully be productive and decrease the burden from a financial standpoint on the workforce maintenance. So let's again call the question whether or not we are going to see some silver lining benefit to Omicron kind of extinguishing or consuming all the oxygen in the air from the fire, if you would, right? The notion, if you're familiar with how they put out oil well fires, they kind of cause an explosion that blows out all the oxygen, I'm paraphrasing here, and prevents the oil from continuing to burn, right? That's kind of, in short, a very crude way of looking at the effect that Omicron, some hope Omicron will have on the global population and cause this natural immunity at a huge scale to prevent individuals from being susceptible to the extent that we become more of an endemic picture for COVID-19. So let's play on that and let's see and visualize with data where we would need to be for COVID-19 to be endemic, right? Some say, well, hey, we're approaching that. Let's call that the question, right? So let's look at an endemic illness, influenza in this case, the flu, and let's look at some statistics around it. This is 2019 data, 2018 data, looking at the percentage of individuals in the US fully vaccinated against the flu. Okay, and if we look at adults 18 or older, that number is 46.8. And obviously we have the breakdown of the demographics there amongst the individual population, 65 and older, at 68.7%, right? And so this is the state of our annual vaccination efforts against influenza, which is an endemic illness here in the US, right? Here's the mortality numbers now, same data in terms of 2018, 2019 statistics of influenza. First, we have influenza and pneumonia deaths, right? But let's zero in on just influenza by itself here at the bottom. The number of deaths in the population per 100,000 is 1.8, all right? 1.8 deaths per 100,000. If we reduce that to per million, right, we're at 0.8 deaths per million, right? And so now let's examine where we are with COVID-19 so that we can compare, are we even in the vicinity of having an opportunity for COVID to become endemic? And then we'll continue to pay attention to these stats in these webinars subsequent to this month, obviously, and continuing to have Omicron play out. So right now, where do we stand with our vaccination effort for the pandemic of COVID-19 here in the US, right? Fully vaccinated, let's at least one dose, we're at 73.8%. Fully vaccinated, we're at 62.2%, right? And so we're higher now for COVID vaccines than we are for flu vaccines. All right, this will be important, and we'll come back to this in 2 seconds here. If we look at even boosted doses, we're at 34.7%, right? And let's not be mistaken. Again, I want to point out for a moment that CDC, it's not a matter of if, but when they're going to update their definition of fully vaccinated to include boosted individuals, right? Again, Israel having the highest, one of the highest populations of boosted populations, and still experiencing the spike in effects from Omicron. And so we expect and anticipate a change in that definition, perhaps shortly after we have a final determination on the ETS from the Supreme Court. So as we examine the percentage of individuals vaccinated against COVID, so we can compare against influenza, looking at the deaths, again, revisiting that 1.8 per 100,000, 0.18 per 100,000. Now let's flip back to our death of COVID, right? Our death rate of COVID. And we can see where we stand here in the US. If you kind of zoom in to the bottom right, we'll fast forward there and look at Omicron, right? At the end of the day, here's where we would have to be with regard to our new deaths per million to call COVID-19 an endemic disease comparatively as we do with influenza, roughly. Okay, so we're a factor of not just 10, but a factor of 100 above that number in terms of deaths per million, not just in the U.S. but abroad. Okay, so we have a lot of work to do, and that is why we're still not taking our foot off the gas in regards to the impact of COVID-19 on the workforce and in the general population, right? I did a recent interview on a news channel out of Florida, and the reporter asked, so what's the big deal, right? I come to work sick, I give you the flu, I give you a cold, not a big deal. I give you COVID, everybody freaks out. This is the why. This is why, again, what we just finished talking about is why it's still important to prevent COVID transmissions, because there's increased risk of poor outcomes, there's increased death rates amongst the population here in the US. So examining now, zooming out, examining South Africa, right? It's an important metric to look at because we want to understand how Omicron in particular played out in South Africa in regards to the population that were infected, the number of new cases versus the number of deaths. This is kind of fast forwarding where we are now and trying to understand and predict, are we going to continue to see a rise in the deaths here in the US from where we're at, or is it going to be and play out like it did in South Africa? We don't see the similar spike in deaths that we have seen with previous variants and waves here in South Africa due to Omicron, right? Again, pointing in a positive direction in regards to hopefully we will not see the level of deaths here in the US, and surely the data so far is pointing towards that, right? But yet and still, that because of the sheer number, again, this is new deaths per million, right? But because the sheer number of infections, the total deaths may still be very substantial, because we're having higher spikes of infections than we had previously. So we want to be still cognizant to the sum total loss of life that may be preventable. And surely if transmissions happen in the workplace, 2 of them last week with companies we work with, we learned were likely occupational exposed COVID cases that ended up dying from the illness, right? And so will we see more of that? It may be likely, and obviously doing whatever we can to prevent loss of life, and certainly the unintended impact to the business as a result of a work-related fatality if the transmission was indeed a work occurrence, right? So again, death lower, Omicron in South Africa. As a result, we'll likely see lower numbers here, continue to see lower numbers in the US. All right, we got about 27 minutes left, so we'll pick it up here a little bit so we have time for questions. But should employers, as we talk about, again, trending the pandemic, continue to prepare for ETS, and why, right? Because if Omicron ain't that bad, if this is as bad as it gets, should we be doing more, right? And certainly we know, first and foremost, compliance is going to be key to prevent the penalties that may be enforced by the feds. We know the Supreme Court is going to weigh in this Friday on the 7th, and we hopefully will have some indication of whether or not ETS will be in play moving forward. Now, with that being said, we know that the Supreme Court has previously upheld state mandates to this extent. But again, there's a little bit higher burden for the Biden administration. We will see how it plays out amongst the Supreme Court. So we're going to now switch gears, and we're going to look to you to give us some data and share that data amongst yourselves and update us on what your experience and what your plans are to, one, be compliant and do a little bit more perhaps, and compare that to roughly 2 months ago. So back in November, here's the survey that we did, and here are the results. What strategy will you likely use for managing ETS compliance? 23% of you said outsourced, 47% integrated into your internal processes, and 30% said integrated as internal as a standalone process. When we asked, have you already made a final determination? 22% said yes, 78% by far and large said no, right? And so the last question was, approaching, what approach would you use in general for your organization? Enough to be compliant is fine, 36%. Beyond compliance was at 40%. And let's maximize everything we can do to protect workers was 24% against flu, cold, etc. Right? And so let's pick up the phones. I want you to pick up your mobile device. You can do this on your computer. I want you to go to slido.com. So join us, slido.com, and we want you to enter this code, 826403. All right, I'll leave this up here for a second. Actually, we'll switch over the screen here, and we'll have you, while you're joining, again, slido.com, 826403. We'll give you a couple seconds here. Awesome. We got folks joining in. Good, good. So while folks are joining in, I'll speak to, we'll give you a little bit more time here. We'll speak to briefly the new CDC guidance, right? The guidance primarily that CDC has updated is to help by far and away the workforce deal with the demands and the shortages of workers being present in the workplace, right? As a result of quarantine or isolation. So let's see, I just got a question, put the slide back up. We're getting some questions here on the, nice, on the survey here. So let me, I think a lot of you have joined here. Let me quickly just actually switch this over and go to our live view of the questions. Let's shrink this down here. You all should be able to see this now. And we will start. Let's go ahead and jump into the first poll. So you can see that pop up on your screen here. What strategy, again, same question, what strategy would you likely use for managing ETS compliance with where you're at today? Excellent. Numbers climbing. 70 of you have responded, 82. We have about 239 of you on today. I think that's a record in recent months here. So we appreciate you joining, and we hope you get value from understanding what your colleagues are doing to manage ETS from this perspective. Excellent. So we're having a higher percentage than last time if we compare of individuals who are doing an internal integrated process. All right, good, good. All right, as you continue to answer that, let's go ahead and go to the next poll here. Have you already made a final determination on your ETS compliance plan, signed agreements, new hires, dedicated roles, etc.? Excellent. Love the fast fingers out there. Good deal. And this is important because we will speak to some of the best practice we've seen in terms of how to lay out and partner and do internal processes briefly towards the end of the presentation here. Okay, good. Higher percentage than last time in terms of having made a determination of the path forward, both internal and perhaps external. Good. All right, final question here. What approach then closely reflects your organizational strategy? Enough to be compliant is fine. Beyond compliance to protect workforce is ideal. Let's maximize every opportunity to prevent workplace transmissions altogether. Excellent. Okay, this is good. This is good. All right, roughly about 115, 113 right now. So good. And so what we'll do is obviously we can send out these results here, but I wanted to be able to show you all live what your cohorts are doing and how they're tackling ETS from this high level. All right. So let's switch back to the PowerPoint here. Thank you for participating in that. And so, so let's talk about the fix, right? Let's talk about the best practice in regards to what you need to have laid out, what you should have laid out, what the compliance looks like. And this is just from gathering, what we see in the marketplace, right? Whether it's work care providing the service or whether it's Salesforce or SAP, all have some type of solution, it seems these days, around COVID management for the ETS. And here are some of the things that we're seeing. The strategy for compliance best practice, right, is kind of juxtaposing PCR versus rapid antigen, right? And so we want to talk about that strategy, because what we know today is that rapid antigen tests as a result of Omicron are not as sensitive and as a result may not be detecting positive cases as efficiently as PCR tests. And so we are seeing a shift as a result of that updated data around efficacy of rapids towards a PCR strategy. And certainly doing PCR is something that all of you should be familiar with at this point. It's been around and was the first before Rapid showed up, and now is not experiencing as dramatic, if any, of a supply issue as we've experienced with rapid antigen tests. So keep in mind, there's still strong use cases for rapid antigens, but PCR can be used to do surveillance testing and keep you compliant. One of the benefits, obviously, of the ETS compliance with using PCR versus rapid antigen is the need to not have to proctor PCR, right? We know the ETS speaks towards proctoring being only those tests that are both self-collected and self-reported, so that PCR or anything that's sent to a lab is not privy to that rule and can be done in a more simplistic fashion from home or remotely, etc. So that's the strategy for the PCR versus rapid. Now, vaccine verification, test tracking, hopefully is something that at this point you're doing, whether internal or external, in some type of digital platform. We've seen where you take a picture of the individual, the worker takes a picture of their vaccine card, front and back perhaps, and some type of AI typically would first look and verify that yes, this is a expected image of a card or a doctor's note, etc., and verify that the information on it, right? Certainly a manual process of having to review that with eyeballs is still a process that's prevalent in the workplace, but we're seeing more and more leveraging at scale, automation and artificial intelligence. So hopefully you've been able to take advantage of some of those tools to both validate as a requirement of ETS, right? No longer can we do an attestation. You have to have documentation from the employee and hold that data so that you're compliant. And this is one of the ways and solutions and best practices we've seen. Having a nurse on site, that is an option that we see employers taking, because when you have a sizable workforce and you're trying to get through on-site testing, whether it be PCR or rapid, right? Having that on-site nurse may provide an advantage for, from a temporal standpoint, right? Alleviating a bottleneck, as well as helping with, if you're shipping PCR tests to a lab, being able to do that part of it. And so that your EHS team is not having to do those administrative and, helping actual collection of samples from the workforce perspective. And then lastly, in terms of best practice, it's not an actual component of ETS, but a best practice as a result of where we're at with regard to both vaccinated and unvaccinated experiencing symptomatic infections. right? And transmissions. And that's doing what we had to do from day one, way back when, of 2020, which is the symptom tracker, right? And so still having a daily symptom screener tracker in place is something that not just we believe to be best practice, but obviously is going to be the component that helps prevent the fully vaccinated, boosted individual who has a runny nose and unfortunately may still have COVID from showing up to work ill just because they believed it's a cold because of their vaccination status, right? And so that's a critical component. If we're looking at, the complete management, best practices end to end, obviously there are solutions out there that will help with your scheduling on a digital platform, do return to work management, as well as access to a dashboard and telehealth support, right? So we see these solutions out there, and we know that, there may be pieces of it that you can pull into your internal operations and leverage. We believe in time, obviously, we'll see what happened. We'll see play out what happened last year, where there was a tremendous burnout from internal teams from an EHS standpoint of doing COVID management, and more leveraging third parties will likely be over the next 2 to 3 years of dealing with COVID. What plays out here, again, beyond just compliance with ETS. All right, and as we have a couple minutes left here, let's finish with just the messaging, right? Keeping it simple and hopefully sharing that with your population of workers. More is better for everyone, right? That if you're in a community in which there is no mandate from a county or city or state level, right? Still having some type of in place mask mandate for your workforce is going to be prudent to help prevent asymptomatic spread as well as symptomatic spread, right, in the workplace. So communicating to the workforce that, yes, we're going to go back to doing a little bit more to help protect and save lives, hopefully. But at the end of the day, if we're all doing this, particularly around vaccinations, then we may accelerate our return to normal by way of having less people in the susceptibility pool if we're talking about the vaccination route, right? So it's a kind of continuum, again, of and underlying the argument of why we should be doing a little bit more than just compliance to help protect the workforce. And certainly based upon your responses, you all are leaning towards that as well in terms of doing more than compliance, particularly with the circumstance we find ourselves in today with the constraints on the workforce. So with that, we'll stop. We'll get into the questions. Thank you for joining, and we'll hopefully get some details answered here. And I see we have a number of Q&A, so I'll let Karen take it away here.
Thanks, Dr. Harris. Could you go back to the slide that shows the death rates per 100,000? One person wants to see it again, and then there's a couple questions related to that slide.
Absolutely.
One question is, are there less deaths from Omicron because of protection from vaccination, and or is the Omicron variant less severe in general?
Sure. So just to clarify, this is deaths per million. In the CDC comparison that we did of the flu, it was 100 per 100,000. If we reduced it to a million, it was 0.18 per million. But there is clinical suggestion of both, right? That populations that have experienced previous infections, high rates of infections in the past may have some level of protection from an immunologic standpoint, which is certainly what we theorized in South Africa as well as here in the US. If we look at seropositivity rates from CDC of laboratory reports, the seropositivity rates are approaching 40–50% in some states, right? Meaning 50% of the population having had COVID-19 previously. And so what we know to be likely the case is that that imparts some protection on severity of illness and hospitalization. But certainly, even amongst the unvaccinated population, even amongst those who are naive to the virus, we're still seeing, in general, lower rates of hospitalization across the board, lower dependency on ICUs, and oxygen use. We saw that first in South Africa, where fewer individuals who were admitted to the COVID ward in the ICU required oxygen as a result of Omicron infection. So we've seen that now play out in multiple nations and hold that Omicron presents a lower risk for severe illness because of the nature of the virus itself, in addition to existing immunity in the community.
Okay, and a related question is, are COVID deaths counted as people who died with COVID or as people who died from COVID?
Sure. So died from COVID is the definition of COVID deaths, right? And I know there's been an ongoing consternation around how individual deaths are coded by the clinical community at the time of death, right? But by far and away, the clinical logic for declaration of cause of death is it should be from COVID, not just died with COVID. Meaning that if you had metastatic cancer, right, and you had liver failure, succumbing to that versus that, along with having a positive result of COVID when you were admitted to the hospital for your underlying condition, would not be the same from a coding standpoint of this person died from COVID-19. It would be the individual who is admitted with underlying clinical condition consistent with a COVID-19 infection, which would oftentimes, if not the vast majority of times, involve the respiratory system, respiratory failure, et cetera. So it is a distinction that I think does not pose any admixing or misrepresentation of true COVID deaths versus deaths from other causes, because we do have data on that, deaths from other causes versus deaths from COVID.
Okay, thank you for that clarification. Jumping into some other questions, trying to take them in order, but they kind of, some of them are very similar. Regarding at-home tests, quite a few folks are initially testing negative, even while symptomatic, and then later testing positive. We've heard they are more accurate if you swab your throat and then your nose. Should we encourage people to do this when they test to get a more accurate result?
So I am not aware of any manufacturer literature around improvement of accuracy of rapid antigen tests from the method of collection, right? Certainly the method of collection is something that is FDA EUA authorized, right? But there's no evidence to suggest yet that I've seen doing a throat swab, then a nasal on the same sample would provide a better sensitivity for that particular test. Can it hurt? No, it can't hurt, right? But will it lead to better accuracy? That is a big question mark and not something we could stand behind right now. Now, we know different rapid tests have different levels of accuracy or sensitivity. And we know there are even some PCR tests that are on FDA's list as not being as sensitive because of Omicron, but the vast majority of PCRs that we know of do detect Omicron.
Okay, here's another question about testing, which is related to determining readiness for return to work. What guidance is there on testing symptomatic or positive individuals at the end of their isolation or quarantine period to confirm they are no longer shedding virus that could impact others in the workplace? PCR versus antigen test.
Sure. So that question kind of goes back to days of old, early in the pandemic, where in order to return to work, it was recommended by CDC or required that you had 2 negative tests 24 hours apart. And at that time, it was PCR. Right. And then we learned that after a period of time, individuals are not likely shedding sufficiently to actually produce a transmission. Therefore, we did not require testing in addition to the supply issue on the testing side. As it stands now, that is still clinically, let's call it valid or clinically rational to clear someone to return to work without testing being a necessary component of that return to work process after being positive for COVID 10 days after still your initial positive test or initial onset of symptomatology, right? So that logic and that clinical reasoning has not changed. What has changed, however, is how do you get workers back to work sooner, right? And minimize risk for transmission in that scenario of returning someone to work less than the 10-day time period. And that methodology, as it stands right now, still does not require testing. It's suggested in the new CDC recommendations at day 5, right? But it's not required necessarily. Will that change? I think it might. That's the rumblings amongst some of the clinical community that CDC will update that to suggest testing is required to do an early return to work. And there are jurisdictions that still won't, that don't agree with CDC recommendation of the 5-day return with masking, if not tested, right? So there are nuances in it, but at the end of the day, testing is not a requirement for a return to work at this point in time because risk is still minimal if it's been a 10-day period.
Okay, so this is another related question, which kind of goes back to previous recommendations. What guidance is there on testing individuals who've had COVID in the past 90 days when they have a close contact or start experiencing symptoms? Because it was presumed that you wouldn't be contagious for 90 days. Is that still a consistent recommendation?
That is still a consistent recommendation that you're presumptively not a positive for COVID if you've been exposed, right? Unless you have onset of symptoms. So that's the threshold. Exposure in and of itself within 90 days does not require you to quarantine if you've recovered in that time period from COVID. Same regard to being fully vaccinated, right? You're not required to quarantine from an exposure. Now, that's a one-off exposure. That's not suggesting someone who lives in a household with somebody positive for COVID. That's a different scenario. But nonetheless, it is best practice for an individual with symptoms after an exposure, regardless of when you previously had COVID, if you have a known exposure, to test to make sure that you're not positive again for the illness. So I don't want people walking away from this thinking, even if you're symptomatic, that if you're within 90 days of having recovered, that you're in the clear. That's not, obviously not 100%. And still best practices test anyway with that known exposure in that timeline.
Okay, we have so many questions. I'm sorry, we're not going to be able to get to a lot of them, but we will follow up in, as I said, and post it on our website. We have time for a couple more. Is weekly testing really adequate? It seems like the time frame from exposure to contagion is greater than 5 days, making weekly testing potentially ineffective, but better than nothing.
And that's absolutely correct. In regards to better than nothing, right? We know that the data from Columbia University that we reported on some time ago and reviewed on workplace transmission kind of follows this rationale, right? Let's consider compliance in this case, which it is, weekly testing, right? Doing more than that can provide and impart additional protection for your workforce. In particular, Columbia University looked at weekly testing 3 days a week, and testing daily, right? And obviously, the more you tested, the daily being the most frequent, the lower the risk for workplace transmissions. So we know you can do more and provide increased protection. The question is the cost worth the return on investment, right? And so that's kind of where we're at now. And the basis for making this argument that doing more at this point in time, because of the impact to the productivity and success of the business, is now back in question, having entire lines of workers out of work because of COVID infections. It's now shifting towards doing more at a higher cost will still provide increased return on investment.
Is there any data on the current COVID breakthrough rate for fully vaccinated and boosted individuals?
I have not seen updated data on the breakthrough. In terms of symptomatic illness prevention numbers, we know that even after a booster, the risk of symptomatic illness goes down substantially. If we look at Israel's data, the protective factor goes from 37% up to 92% roughly, right? And so it's still a question of how long after a booster is that number maintained, and to what extent does it wane over time? Anecdotally, it's looking like your immunity still wanes over time in terms of your risk going back up. We just don't have enough data to suggest how low that waning immunity goes. Certainly with new variants, that throws the entire equation off in terms of waning immunity, because these new variants like Omicron just simply escapes the immunity from either natural immunity or acquired immunity through vaccination.
Okay, one last really quick question. We're out of time. A lot of people noticed the data about India and how the case rates there are so much lower compared to other countries, and they're wondering if you have an explanation for that.
One is, in general, the proximity in terms of population density overall in the country, right? But if we look at the data itself, some theorize it's just being underreported due to lack of testing. Not too dissimilar to our numbers, right? We're reporting higher numbers in the US, but we still know that our positivity rate, if you look at the data on seropositivity, the true number may be double, in some cases almost triple what we're actually picking up through testing. So likewise, logic follows that in India, due to lack of access to testing, the numbers are just underreported.
Okay, there's still quite a few questions about CDC guidance. And for those of you who still have questions about that as they apply to your specific workforce, feel free to correspond with us at communications@workcare.com, and we'll forward your questions on to our medical team, our physician group, and we'll get back to you.
And one of the
thanks
reasons
again for your time today. We really appreciate you joining us. I think we certainly set a new record for this year with attendance. I figured we'd have a good turnout and lots of questions. So we'll see you in a month. If we schedule a special webinar to answer your questions live, we'll be sure to let you know. Thanks again, Dr. Harris. We really appreciate your insights.
Sure. And one of the reasons I didn't spend a whole lot of time on the new CDC recommendations is because WorkCare will be producing, as we've done in the past, a one-pager most likely to help you all understand the new recommendations and some of the pros and cons on either side. So look to that. I'll be working with Karen to produce that and push it out to everyone. But thank you for joining once again. We, as always, wish you safety and God bless.